Uh, Good evening, everyone. We'll start the next session. My VIP patient. Any patient is a VIP patient for that matter. So we will start with the first one, flashes and floaters, Dr. Sudipta Das. Sapnesh Savan. Sapnesh Savan. Next one is Dr. Sapnesh Savan.
10 मिनट का ठीक है आ रहा है जब बोलोगे तब दे दूंगा ठीक है
पॉइंट है ना पॉइंट Thank you, sir. Good evening, everybody, and I would like to thank AIOC for this opportunity. So the topic is, I was not really sure about how to go with this, managing a VIP patient with complaints of floaters and flashes. We get regular patients on this, but how to manage in a VIP patient. So the outline of these presentations will be on VIP patients, how to define pathogenesis, symptoms, and simulating conditions, counseling a VIP patient or any patient per se, management, and persistent asymptomatic floaters or symptomatic floaters. So the first we come to what actually is by we mentioned by VIP patients. Is this VIP, this phrase actually describes the elevated social status afforded to influential and prestigious members of society, including politicians, executives of major companies, celebrities, as well as other prominent individuals. And you all encounter patients who are considered VIP for one reason or another. And proper management of these VIP patients can offer downstream benefits to your practice or academic institution in the form of bolstered reputation, practice growth, and funding. So there are a few things we have, but what actually is a prerequisite when you start seeing these patients? I feel there are a few points which I felt important, caring about this patient's person status, and rather to simply treat them the same way you treat anyone else with the same eye problem. It's okay to roll out the red carpet, but make sure the office is clean. The waiting period should be less. Offer preferential appointment scheduling to accommodate the VIP schedule. And your delivery of healthcare to the VIP patient is no different from your delivery of healthcare to any other patient. So we should not forget this, the last days of Michael Jackson. Avoid VIP syndrome when doctors allow a VIP patient's broader social status to influence medical decision making. The consequences can be dire. Don't get distracted or diverted by the VIP status. Think clearly, be relaxed, and stay within the standard of care. So the first point is floater. These are dots, specks, lines, circles, cobweb, which we see in the visual field. They appear outside there, but actually they float inside the eye. Tiny clump of vitreous cells which cast shadow on the retina, and most noticeable when you see a white background or a blue sky. So these are all annoying. So usually the assurance that usually decreases after a few months once you have a vitreous separation, but sometimes can be persistent. 50% leads to difficulty in reading, 30% leads difficulty in driving. But I was not aware when I started searching for publications, there were reports of suicidal attempt due to persistent floaters. So this is a small pathogenesis. I think when we explain maybe a compliant and understandable patient has to be explained about the pathogenesis of these floaters. I'm not going into the details of this. Now the second symptom is flashes, physical stimulus of vitreous pooling part of the retina. So usually it appears and fades very quickly. So we have this pool in the vitreous from the periphery or from the center. So we have a retinal traction which causes photopsia or flashes. This is the actual pathology, posterior vitreous detachment, which causes these symptoms. Now, syneresis of the central posterior vitreous, increasingly seen with age, can be precipitated more in myopes, past ocular surgeries, or in trauma. This line I usually quote for almost all the patients, that if you are more than 65, or at least you just can have a small calculation on that, then more than 65% patients over the age of 65 years will have PVD. And their symptoms, intermittent blurred vision, glare or haze, and PVD with complications if at all you have any vitreous hemorrhage, retinal tear, or retinal detachment. So this is the typical PVD picture. The complications, as I was telling, that the first, once you have these patients of PVD or floaters, you should triage these patients according to their age, according to the risk factors. PVD in itself does not require any treatment, but symptomatic patients should be re-examined at 6 weeks, as 3.4% of them may have a new retinal tear. See earlier if they are having new shower of flashes, floaters, or reduction in vision. These are the simulating conditions for flashes. It can be seen in migraine with aura, stays for some specified time, mostly bilateral. You have jagged lines or heat waves. Occipital tumors and vertebrovesicular TIA also can have flashing of flashes. Glares and halos you can see around lamps or street lamps in case of cataract, in case of intraocular lens, post-refractive surgery. Vitreous hemorrhage along with PVD can have retinal tear. So these are also few things you have to find out the etiology. Vitritis is very important when you have a floater. Infections and autoimmune conditions has to be ruled out. And definitely, last but not the least, retinal detachment when you have a shadow along with all these symptoms. So what to do? So examination proper. Vision, definitely anterior segment examination is very important to rule out uveitis. History of any anti-VEGF or any past surgery, which is important to rule out any inflammation. Dilated fundus examination with scleral depression is important to rule out any intermediate uveitis, pars plana exudates. Ultrasound can be of benefit in some cases, but not OCT. Urgent referral to a retina specialist examining or explaining the disease condition. So these are a few things, if you're anterior segment surgeon, probably these are the few things you have to keep in mind. Treat peripheral retinal degenerations according to the preferred practice, what you follow. Personally, I give this Moorfield's guidelines to the patients. Feels very handy, and actually patient's acceptance is much good, along with the dummy eyes demonstration. These are the few illustrations I have in my clinic, which I show to the patients. These are normal retina and abnormal retina, where you have a detached retina. So this, I think, for a knowledgeable person or probably a person which is partially Google trained can actually be more educated by these illustrations. These are the few other diagrams I usually carry with me, the retinal breaks, a small retinal localized retinal detachment, or a detachment almost covering the retina and the central part of the macula. So these are the few risk factors you explain the patients, and you can actually prognosticate, actually explain how a disease process follows, starting from flashes and floaters. When you have a tear, probably these are the pictures where treatment, how is treatment done, how it helps in treating the condition, how it helps in preventing retinal detachment can also be shown by nice illustrations. So these again are the same. We have breaks and lattices where we have fresh laser marks done. These are the old laser marks. So how it barricades the weak spots can be explained with these specific illustrations. But if you have patients who have persistent symptomatic floaters, most eye doctors consider floaters to be minor ailment, but in fact, these are the few things which are already there in the publications. 33% patients have noticeable vision impairment, few have migraine, anxiety, there's 6% patients have anxiety, and as I have already told that 0.06% had considered suicide for persistent floaters. So intervention worth considering in cases with moderate to severe floaters. These are the possible treatments. So NDEA laser vitreolysis I think was done before, but it has a negative impact. Definitely the floaters are being fragmented to multiple floaters. Risk of detachment also becomes more. Floaters only vitrectomy are being tried. These deep anterior vitrectomy during phaco and two poor pars plana floaterectomy. This was one publication in Asia Pacific Journal. Though I'm not very convinced about that, probably we can have opinion from the chair regarding this. So these are all possible treatment options for persistent floaters. This is the information booklet I give to my patients, and especially I explain when you have a VIP patient, probably these are a few things which come very handy from the Moorfield's guideline. And the patients who probably is not understanding this picture sometimes becomes very handy when you treat the untreated eye may come up with this, where there's a risk of losing your vision. So the thing is reassurance in most of the cases. So I need to conclude with this, that sound understanding of the basic pathophysiology of the disease is very important. Even the symptoms are very mild. Treat VIP patient as any other patient with needed modifications in the approach, not treatment. Floaters and flashes can be annoying, and the key word to handle this symptom is patience for both the parties. Follow preferred practice pattern as we all do. Accurate examination with illustrations is a must. And in very rare conditions, surgery may have some benefits in case of persistent symptoms. Thank you so much for your patient hearing.
Thank you, Dr. Sudipta. So as I said, the VIP patient is any other patient, but you have to give a good communication you have to have a good communication with the patient, that's all. First you have to identify which is a dangerous flashes and ordinary flashes, and dangerous floaters and ordinary floaters. So that is the main thing, because we should not miss any break or anything like that. So sometimes the patient will say, I get flashes when I enter a dark room or something. It may not be very significant. That is, suppose nighttime flashes may persist for a few months. That is one thing. Then sudden movement of the eyes. It is called Moore's lightning streaks. Sudden movement of the eyes or head, you can get sometimes one flash. That is also not very significant. But the real flashes is very annoying. So, and when you see little vitreous hemorrhage and you don't see any break, the most important clue is to call the patient after a couple of weeks or a week later and re-examine. So the patient also will be reassured that if nothing is going wrong, if you can take a photo and document it, best. Because sometimes on the first visit we will not see any break. After the first visit you may see a break. So these are few things. And floaters, some people will come and say 2 dots I can see for 3 months. It may not be very significant. Sudden onset of large number of floaters is the warning that problem. So these are some of the points that I would, yeah.
Change in symptoms is important while counseling the patient. Means people will say, yeah, I've been seeing floaters for months. That doesn't have much meaning, but you have to ask the patient to keep a note if there is a sudden increase in the number of floaters, not from 1 to 2 or 3, 1 to 10, 1 to 15, that is significant. And sudden onset of flashes many times a day. If the patient is having flashes once or twice a week or so, no significance as long as the retina is okay. But you have to tell the patient that if you suddenly start seeing lots of flashes in a day, every hour, you have to immediately show. And you have to tell the patient that the examination is important. Just by informing won't do. Many patients say, will call up and discuss it. These things cannot be discussed. These things have to be seen. Then only you will know. And the important part is fresh breaks can develop. After, suppose a patient comes to you with acute onset PVD, you see a break, you treat it, make sure you call the patient for follow-up because he may have new breaks during the follow-up. So,
Okay.
Yeah, just one small comment to add. It's not just the question of a VIP patient, for any patient for that matter. A lot of patients, when we do not find anything on the retinal examination, we tell them everything is okay, would not probably want to come for a repeat visit. But if the complaints of flashes and floaters are significant, you must always stress that there are certain number of patients who, approximately 3 to 5% patients who can develop a break, fresh break in the first month. So that is something that we tell our patients. And sometimes VIP patients do not want to come for whatever reason or their schedule or travel. We usually tell them to make sure wherever they are to get a retinal examination, dilated retinal examination.
and please document it. Documentation is important.
And also make sure to tell all the patients who are post-operative to for sure come for a follow-up, because with the high volume cataract and refractive surgery going on, we do see a risk in these patients, especially with complicated surgeries. So these patients for sure, because they have a tendency, because they're VIP, to get a phone consultation or a teleconsultation. So that's something that we must avoid.
Thank you, Dr. Sudipta. We will go to the
Thank you,
next talk. Change in the order. Dr. Prashant has some other commitments also. So Dr. Prashant will be speaking on blunt trauma to the eye, what to do.
Yeah, thank you, Chair. So even if it is a Donald, as he came to my clinic, you first foremost thing, as Dr. Sudipta shared, that you have to remember, you have to be you have to reassure them, even if it means to be a Donald. Okay. And most importantly, you have to keep yourself composed. Even if he is a VIP, he should be treated as an ordinary patient. Then only your clinical acumen will be put to proper use. Don't get bogged, whoever be it. So be it what? A patient, when he walks into your OPD, first foremost thing is reassure them when he comes with a blunt trauma. If he has accompanying children, hand over the custody to some caregivers, it would be better. Most important thing is to rule out any other signs beyond eye about the life-threatening injuries, and assuring them all is well is every time important. So what are the signs of life-threatening diseases which we need to remember when we are evaluating a patient of a trauma? Is a projectile vomiting, a history of unconsciousness, or any ENT bleeds. Any three of these things, if the patient does share with you, First and foremost is to patch his eye and send him first for a complete neurological necessary evaluation. Then the aim of the history here is to differentiate whether the injury has caused an open globe or a closed globe injury. Depending on that, you can assess how fast you have to treat it. Importantly, also you should ask him the history of eye protection, what was the timing of presentation, and importantly, medical drug allergies history should be taken. Also, warn him about further nil by mouth instructions if you're planning to give him a surgical option. Never use a topical ointment, just patch him with an eye shield and send him for further investigations. So how do we begin our evaluation? Remember, letter presentation means, especially in a case of a closed open globe, it means more chances of infection, and so timing of presentation should be noted. These are the routine symptoms which we might ask for. But does necessarily all blunt objects cause only blunt injuries or a closed globe injuries? No. Even a blunt object can cause a rupture, as is illustrated in the image below, and therefore even if the injury by a blunt object, you need to evaluate and rule out the occult globe rupture. So what are the signs which make you conscious that he is likely to have globe rupture? It is the light perception, which is visual acuity reduced to perception of light, chemosis, subconjunctival ballooning hemorrhage, subconjunctival hemorrhage, hyphema. These are the indirect signs which will give you the clue that probably in spite of having a blunt injury with a blunt object, he can have a globe rupture. So where do we look for predisposed sites of anatopic rupture? There are certain weak areas on your sclera where the sclera is likely to give away. And which are those anatomic sites? Well, ciliary body region, the intercalary region. These are the region where you should look for equatorial region and rarely in the posterior along the optic nerve in and around. These are the predisposed anatomic sites. When you receive a blunt injury, you can have a rupture. And this, if you have a pre-existing surgical wound like a SICS wound as you see, or a RK scar or a PK graft, those blunt injuries can lead to an open globe injury. Other thing which you need to remember is about 7 rings of globe. Why do you need to remember? It's not only for your study purposes, but these are the areas when you receive a blunt injury to look for. So, and these are the things which you will look for: sphincter tear, cyclodialysis cleft, zonular tear, dialysis. These are the 7 sites of blunt in a blunt trauma where you have various injuries, and these are the areas which you should predominantly look for when you are evaluating. Equally important is to the prognostication. How do you prognostic? If it is a rupture, that is an open globe injury in spite of a blunt injury, it is the zone 1, zone 2, zone 3, how we decide. I have shown on, this is available on any standard textbooks. Post a more zone, bigger the zone means zone 3 is poorer prognosis. Similarly, in a closed globe injury, if the injury is this yellow area external, then it is slightly better off. Zone 3 means more severer injury. And it is always important to prognosticate based on these various OTSI scores, and so that bigger the OTSI score, remember, better is the prognosis. So how do you evaluate a patient? It should be always detailed and thorough, and you should follow this sequential step-by-step approach even if he is a VIP patient or a non-VIP patient, and move slowly. Visual acuity, initial visual acuity is prognostic importance, and therefore record visual acuity of both the eyes. Visual acuity of 6/6 does not exclude serious eye complications, always remember that. Then comes the pupillary evaluation, the size, shape. You look for mydriasis, look for RAPD. External evaluation with the torch is equally important to rule out enophthalmos, retrobulbar hemorrhage, a blowout fracture as you see from the position of the globe. Palpate the orbit for crepitus and bony deformity, and in doubt, always don't hesitate but go for exploration. You can evaluate extraocular movements and visual fields if it is a closed globe injury. Slit lamp examination, these are the obvious signs of rupture where you see lamellar length or with a uveal prolapse. This is again a pig pupil with a iris tissue insection. While if you see a foreign body like this, wound of entry, well, you know it's a open globe injury, what type of a management you need to do. But equally important, you should be aware of the occult signs of rupture. A subconjunctival hemorrhage where posterior extent of it cannot be traced. Or you see a circumscribed match, that is a lentosil. Or you see a uveal show, for sure it's in spite of blunt object injury, it's a occult rupture and there is a side opening there. These are the other signs of doubtful rupture: a conjunctival tear, a deep anterior chamber, or a posteriorly retracted plateau iris. Again indicates towards a open globe injury. So remember this. Similarly, again you see a subconjunctival hemorrhage without a posterior extent seen. You should always explore in such cases. Anteriorly, if you see certain areas on cornea, if you are not sure, do not hesitate to do a Siddle test. Then coming to intraocular pressure. Low intraocular pressure, in a blunt injury, you can have a high intraocular pressure as well as low intraocular pressure. Taking a manual IOP in a cases of open globe injuries. If you are suspecting a foreign body or cyclodialysis in a case, you should always do gonioscopy, but angle recession can lead to glaucoma later, so this is the importance. The step 6 is to evaluate retina always by indirect ophthalmoscopy. Then only you can see structures, beautiful structures like choroidal rupture, Berlin's edema, retinal detachment with dislocated lens on this. And if it is a closed globe injury, do a slight non-tender, means very lightly scleral depression. And repeated evaluation is must in cases of injury. Remember, you might not have a dialysis or you might not have an obvious dialysis because of a hazy media when you have a blunt injury. But later on, as the vitreous contracts, it can develop dialysis horseshoe tears. Then the step 7 is to do for additional investigation. The foremost is B scan, where you can understand the vitreoretinal correlation, posterior capsular integrity, associated ocular morbidity in the form of lens drop, foreign body, vitreous hemorrhage, retinal detachment, and the signs of rupture which you see on a case of a B scan as this. You see a posterior scleral rupture, collapsed deformed globe, or choroidals. These are signs of occult rupture. CT scan and MRI. CT scan is done to rule out foreign body, and if you are suspecting a posterior rupture, flat tire sign or a scleral rupture can be picked up, and then you need a exploration. MRI is done to be avoided when you suspect a magnetic foreign body. Do you need OCTs? Yes, if you are suspecting any of these posterior segment lesions like this, you can pick up it on a OCT. When do we do VEP? Every patient who has a no PL should be given, in spite of having a no perception of light, should be given a benefit of exploration and if need be repair surgery. Only if VEP is negative, then you are justified in enucleating. So by dictum, in spite of a no perception of light, it is always prudent to give a surgical exploration and repair option to the patient. Now the step number 9 is assessment of the other eye, and always assess the uninvolved eye for various reasons like this. And equally important is further management to protect other eye and regular checkup in future as well. So obvious rupture or in doubt, explore and repair, and always look for things like this when you look at it. So thank you. So be it a blunt globe injury, blunt object injury, always look for occult ruptures. That is the message which I would like to pass on. Thank you.
Thank you, Dr. Prashant. I don't think we have time for discussion. In the next 20 minutes, we have 4 talks.
Yeah.
It's 3:30 already. 3:50 we have to hand over the session. So please, speakers, restrict your talk to 6 minutes or less if possible.
Next one is, I think, Dr. Sapnesh Sawant.
Yes.
Yeah.
The talks are for 6 minutes. So we should be able to finish the rest.
Vitromacular surgeries,
Vitromacular surgeries, nuisance for better outcome.
Nuances,
Nuances, is it?
probably. Is it nuisance?
No,
No, it is written
It is
nuisance.
written like that.
It is written nuisance for a better outcome.
नहीं है presbyopia. Don't declare my age on stage and not there. See, no glasses, nothing. ना वो टाइम आएगा तब करेंगे. अभी नहीं आया टाइम.
It is written nuisance. Nuances.
So, good afternoon, everybody. And
Presentation mode, Vijay.
yeah, it's seen. So I'll try to get this topic into this VIP syndrome session. So vitreomacular traction and epiretinal membrane is what I'm going to talk about, and it may be a cause of the metamorphopsia for the VIP patient that you're facing. Obviously, there could be other reasons like macular hole, ARMD, tractional retinal detachment involving the posterior pole, pre-retinal, intraretinal or subretinal hemorrhage of fluid at fovea. So the tools, as described, there should be a thorough examination, 90D examination, fundus photo, OCT macula, and use all your equipments to diagnose why this patient is particularly facing this problem. Amsler's grid is a good option because that will make the patient aware, and if you're not planning to operate him immediately, it would also help to basically self-monitor whether the symptoms are worsening or no. As said by Sudipta, make the patient aware about the anatomical importance of the fovea in a quick and a lucid way. So I always keep the educational videos on as I speak. OCT macula, especially in these cases of ERMs and VMT, is very important. You should preferably do it on your own and try to do the radial and the raster scans, also HD scans if possible. A very good signal strength is important, and OCTA should be done in select cases. It should be repeated. If you are trying to monitor the patient, then repeat the scan from the same area as previously done. Double mechanism of the ERM is well known, is documented. The damage can be there because of the mechanical traction which causes the Muller cell gliosis, or it could be inflammatory also. On OCT, we do see some hyperreflective dots which also give off this clue that it is an inflammatory epiretinal membrane. So the good prognostic factors before you promise a patient the visual acuity after the surgery should be kept in mind. That shorter duration of symptoms before the surgery is very good for the patient. Lesser central retinal foveal thickness, good integrity of the ISOH junction is preferable. There is a classification which is available so that you can titrate your cases and accordingly counsel the patient. So this is a typical pre-op and the post-op picture of the thin ERM which can be shown to the patient. However, especially in the ERM and VMT, we have to promise that the visual recovery as well as the anatomical recovery may take up to 6 months also. If the ERM is like this, where the inner retinal thickening is a lot more, then we have to try out some nuances during your surgery to make the surgical outcome better. So there is a short video showing the same. Always ensure that the infusion cannula is inside the vitreous cavity. After the vitrectomy near the ports, you proceed ahead. PVD is one of the most important steps. Finish off the core and the peripheral vitrectomy. I prefer to do FGE before staining the membrane. Visualization is the most important clue in ERM surgeries because if you can see better, you can do better. I prefer to start from ILM and move towards the ERM. Instrumentation, you can use ILM forceps also. I am comfortable with a max grip forceps. So if you can see here, this is a very adherent membrane, and when you are lifting up the membrane, always keep a watch also on the appendages of the membrane. Try to avoid the foveal distortion as much as possible. So as you can see, the very thick membrane, and we ensure the complete removal. Always a good idea to do double staining. Even if you have removed this, don't sit back and relax because there could be underlying fragments of ILM, which you can see in this particular case. That there was a bit of ILM which was remaining and which was then later on removed. And always end the case with a complete gas fill. Look out for the peripheral breaks and other lesions if you have missed during the initial vitrectomy before you close the case. So this is the post-op recovery period. However, as I told you again, and I would stress on that the recovery, don't promise 1 month, 2 month recovery because ERMs may take up to 6 to 9 months also, and visual recovery comes much later than that. You could have such a case where there is a shytic retina, and removal again is even more difficult in this, and restoring the anatomy itself would be a great achievement in such cases. So I thought there were a few micro breaks in the periphery also because of the schisis which was noted at the posterior pole. So the peripheral temporal retina was looking very, very fragile. don't lift only from one edge. Try to again and again grasp the ERM and from various directions try to peel it off. You can expect a bit of bleeding, but if it is not a major bleed, then you can proceed ahead. As far as possible, avoid any undue traction on the fovea. So this is how the 6 months post-op result looked like. And this patient after 2 years actually got a good restoration, and this is the recent picture where he's doing quite well, though the functional outcome was not very great. So just illustrative diagrams of VMT with a macular hole. And in this particular cases, like the VMT which is pulled up so much, there is always a risk of iatrogenic macular hole. So we could be doing a PVD, a very, very gentle PVD, and maybe a fovea sparing PVD also in these cases. One could use IVT or dexamethasone. The LVPI group has published reports with Ozurdex and ERM giving very good results. And there is a controversy whether you peel the ILM or no, and that's for the house to discuss. So ensure a complete PVD, adequate staining, probably a repeat staining, lift the ILM along with the ERM is what I follow. Watch out for the appendages of the ERM, avoid foveal distortion, and watch out for peripheral lesions. And in a VIP patient or in any other patient, don't overpromise. We can speak about anatomical versus functional success, longer duration of post-op recovery, especially in the ERM cases. Discuss about cataract and glaucoma possibilities. And my standard statement is the metamorphopsia will reduce or be halted, but may not go off completely. Thank you so much.
Thank you, Swapnesh. One point that I would like to add is that especially in these patients with VMT or pre-existing severe macular edema, cystoid macular edema, even while you're doing the ERM, to try to avoid to peel across the fovea.
Yes.
Try to circumferentially peel it and bring it to the fovea and then just take it off with a cutter if need be. Because even in those cases we can then therefore avoid iatrogenic, never across. We should try as much as possible. Anything else you'd like to add?
Yeah, I usually always prefer to leave IVTA at the end of surgery because almost always in the post-operative period you would have edema. Some edema or the other. So I generally always prefer to.
So when you use IVTA for the PVD induction, some amount of it always sticks around, and even at the end of the surgery,
at the end of the surgery,
you
I
leave
put in a couple of drops of IVTA, even in an air-filled eye.
Yes.
Any when you're filling in oil also, do you ever put in?
Yeah, I would do that very frequently.
A lot of general ophthalmologists may be here. So in some cases where cataract is there with ERM, it is very important to assess the patient early rather than suggest cataract surgery. A lot of people miss the small ERMs and VMT. So you have to find out how much is due to cataract and whether it is accounting for the defective vision. Just one.
Yes.
So thank you.
And one smallest point, all ERMs don't need surgery. That also has to be kept in mind.
Thank you, Dr. Swapnesh. We'll go to the next talk, Dr. Kumar Saurav, sudden dimness of vision.
This one here, no? 3. 3. Observe. A very good afternoon, and thank you scientific committee for giving me this opportunity to present my talk. So I'll be talking about a VIP patient who has developed sudden dimness of vision. So these are my disclosures. So the crux of this presentation is that any boost which you or anybody can get as a result of treating a so-called VIP or real VIP should come only as a secondary benefit, reaped only because you have done a job well as a patient's doctor, not as a VIP patient's doctor, but simply a patient's doctor. If you have done your job well as a patient's doctor, there will be dividends. So there can be a VIP, there can be a general patient, but the treatment remains the same. This is, I could have completed my presentation here only. There is no difference. The treatment remains the same. So going forward, what are the causes of retinal causes of sudden decrease in vision? Most dreaded is the retinal detachment. When do you suspect that the patient might have developed a retinal detachment? When you get a call from a patient, a VIP patient who you know is a high myopic, who is complaining of a sudden decrease in vision, some curtains or veil is falling in front of the eye, there is no pain, and the person is saying that in the morning he was able to see in the left side, but now by the afternoon he is not even able to see the left side, it is completely lost. And if he also reports that he had seen some flashes and floaters, and most importantly, if he has also reported some trauma to the eye, he is a politician who has had some election rally and he has some trauma, then and all these symptoms point towards retinal detachment, then what do we do? What we do is to call the patient immediately for a checkup, and thorough indirect ophthalmoscopy is needed. It doesn't matter if you have optos or any ultra-wide fundus photo machine. It's good to have them, but indirect ophthalmoscopy is of utmost importance, because it gives you an opportunity to depress and see in 3 dimensions. So many times the breaks which will not be seen without depression will be evident if you depress, do the scleral depression. Obviously, we do the fundus photography and ultrasonography to document, and documentation is equally important in a normal patient and in a VIP patient. Assessing the fitness for surgery is very important, and plan for the surgery. There are scenarios when we can treat the retinal detachment where it is very localized subclinical with laser, but most of the time surgery is needed. What additional do we do for a VIP patient? You will be ready to pick phone calls from unknown numbers. You might be getting so many phone calls regarding this person, and you should be picking the phone calls. At least your secretary should be picking all the phone calls in coming few days. If you're outstation, you cannot say that I'm outstation and I cannot examine you. You need to connect him or her with a colleague who can take care of him or her, and the VIP should get or the patient should get what is needed. Whenever this patient comes to your clinic, you have to say hello before your optometrist does. You should be the first point of contact for that particular VIP, because he will come to you, not to the clinic and not to the hospital if you are working in a multi-specialty or multi-ophthal hospital. So, and expedited post-operative visits are needed for such VIP patients. So these are additional things which you will need to do for retinal detachment. Next is CRAO, which is also a retinal cause of sudden loss of vision. Most of these patients have comorbidities, long-standing. It's a painless loss. And the feeling the patient will tell is complete loss of vision. He is not able to see. Sometimes patients come and tell, okay, Dr. Saab, I feel my right eye is closed. Somebody could open my eye and then I can see. He will not even realize that his eye is open and he is not able to see. He feels that the eye is closed. That's the grade of decrease in vision in CRAO. This is not associated with any floaters and flashes. And over a cup of coffee in the morning or a cup of tea in the evening, the patient can say that suddenly after 5 minutes I was not able to see in the left eye, I felt my eye was closed. So this kind of sudden decrease happens in CRAO. What to do in such scenario? Call the patient immediately. Most importantly, if we can say that there is one indication of emergency and early visit in a emergency setup is CRAO. Indirect ophthalmoscopy, fundus photo are routine. Digital massage and paracentesis, as we all know, will work only within first few minutes and hours of the CRAO. Measure the blood pressure, because most of the times these patients are going towards acute myocardial infarction or going to have CVA in coming days or weeks. So measuring the blood pressure at that point of time is very important, because it may be, systolics may be in 200s range. Consider pros and cons of surgery, because surgery has lot of pros and lot of less pros and lot of cons in CRO. Blood investigations are must for every purpose, and for medical legal issues also you need to investigate why CRO has happened, because patients can die after CRO because of other cardiac issues. Prompt cardiological referral is most important, and that's what we can do for this patient. What if this patient was a VIP? Again, you need to be ready to pick phone calls, and you have to connect this patient to your colleague if you're outstation. and you can get a colleague, opthal colleague, to examine him or her, because you are going to tell that Mr. XYZ, you are not going to gain most of your vision. You may gain some vision if you are lucky, but you are mostly going to remain like this. So this is a scenario in a VIP patient is a little difficult. So you may want to ask him or request him to get an opinion, not for the diagnosis part, but for soothing his nerves, that what has happened has happened. A phone call to a cardiologist friend is also very important. It can show the concern towards patient, and it can also help the patient tide over any future or near future cardiological issues. Vitreous hemorrhage is another retinal cause of sudden loss of vision. Again, the patient has comorbidities or have had trauma, painless, sudden floating of opacities in front of the vision. Patients sometimes say that, Dr. Saab, I can see red things moving in front of the eye, or black hairs moving in front of the eye. These kind of symptoms also sometimes happen after lifting some very heavy weight or doing some home renovation, and suddenly the patient developed black or red opacities. If the vitreous hemorrhage has happened after Valsalva, there is a possibility that patients might have had a PVD or might need some treatment in the form of if there is some subileum hemorrhage or any retinal break. So the history of Valsalva is very important, and this kind of vitreous hemorrhage usually evolves over days. In the morning, the patient will say that he saw some red spots, some black floaters, and by evening it was complete. So what to do? Call for checkup immediately, blood investigations, explain the course that is going to take time, explain the possible need of surgery. For a VIP patient, you need to assess his lifestyle pattern. They may be stressed. They need to examine. They need to be explained about the flashes, and recovery time will be long if they have a surgery. For CRVO and BRVO or retinal vein occlusions, the symptoms are suddenly not able to read and evolves over days. Again, comorbidities are need to be checked. Blood investigations and explaining of the course of the disease is important. In case of VIP patients, again, he needs to be explained that there may be a need to visit monthly. He needs to cut on his regular work, and he has to visit monthly for intravitreal injections, and obviously need to inquire about the stress and lifestyle pattern of the VIP. So the crux is, the cardinal point side, it is easy to get awed by the VIP status, but we need to stick to the usual standards of treatment for any such patient. A little more chair time will be needed, and you will always be the first contact point for the patient. Can be helpful. Treating a VIP patient can be helpful in many ways in propagating your practice, but do not seek help at the outset to propagate your practice. If it comes, let it come. The tenet of doctor-patient relationships are same for a VIP and for a regular patient. There is no difference. Thank you very much.
Thank you, Doctor. Since we are running short of time, we can go to the last talk. Dr. Manisha, double vision subluxated cataract with vitreous in AC. Even I have 4 o'clock. Few people busy. No, queue. I mean queue. My session.
Below this one.
Yes.
कितने बजे दिया था आपने? कितने बजे वाला? ये तो 3 बजे वाला. ये क्या है ना?
We started at 3:10. No?
Yeah, we got the hall late.
We will finish only this. No discussion.
आपने वो दिया था?
Yeah. So we can start it. We have only 5 minutes warning as crumbs.
इसमें तो नहीं है. इसमें तो है. अब पेन ड्राइव है? पेन है? तो भेजिए नहीं होगी बता नहीं. नाम तो आपका यही है ना? मैंने सनंदा. कौन सा है?
ये
यही पढ़ना वही यही वही वाली
Thank you, AIOS, for giving me this opportunity. And with due respect to the chair, I start my talk. It is subluxation of cataractous lens with vitreous in anterior chamber. Regarding the VIP status, we don't have to panic, and we have to counsel more, and nothing is specific more than this. We have to attend the patient as any other patient. So if we have a patient of subluxation of cataractous lens, how do we go about it? So extraction is considered when the event is visually significant. When visualization of fundus is impaired with equivocal ultrasonography report, we have to look for any subluxated or dislocated cataractous lens. Preoperative evaluation, it aims at looking for any zonular integrity, degree of subluxation, specific etiology, and any complication in addition to the routine investigations. When do we go for urgent intervention? If there is any pupillary block glaucoma, intractable uveitis, if there is lens corneal touch, or there is possibility of amblyopia in children. So what we do in pre-op evaluation in a case of lens subluxation, we have to see how much is the lens pupil coverage. If it is minimal to mild, the lens edge uncovers 0 to 25% of the dilated pupil. If moderate, it covers 25 to 50%, and if it's severe, it is more than 50%. The picture shows the severe kind of variety in this particular patient. So phacodonesis has to be seen. What is the zonular status? Cataract needs to be seen. Subluxated lens edge needs to be seen. If there is a flat lens edge, as it is seen in the upper picture, the remaining zonular fibers, they are fairly healthy and strong. And round means more zonules are lost. We have to see what is the change in the position of the lens with posture. We have to do UBM if there is a zonular compromise. Damaged or punctured lens needs to be seen, intraocular pressure and vitreous status has to be evaluated. So what is the surgical approach? How do we plan our surgery? If there is a traumatic subluxation less than 3 clock hours, attentive surgery needs to be done, nothing more than that. If there is a mild zonular laxity with progressive pathology like in Weil-Marchesani syndrome or in Marfan's, we use CTR. If there is a young patient with progressive disease, we need to have a sutured CTR with scleral fixation, even if there is absence of lens displacement. So what is the importance? How do we go for capsulorhexis? It is difficult to puncture the anterior capsule. Trypan blue has to be used because it reduces the elasticity of the capsule. Penetration of the bag is easier, they say, with the help of trypan blue. Aids in the visualization of the unintended capsulorhexis, and if there is any compromise during the case, we have to use trypan blue. There are different techniques. Crossroads capsule pinch approach is there. We should use microforceps to steady the lens during the continuous tear, and capsulorhexis is centered on the crystalline lens, not on the pupil or on the corneal apex. Minimum of 2 millimeters of margin between the capsulorhexis edge and the equator has to be kept. We have to stabilize the capsular bag when? So if it is less than 3 clock hours of zonular deficiency, flexible iris retractors are placed to the limbal stab incisions. These can be used to hook the capsulorhexis edge and support the bag. Stabilization of the capsular bag in more than 6 clock hours. Bag stabilization done with hooks, retractors or segments for phacoemulsification. The dictum stance, place the CTR as late as you can, but as soon as you must. CTR, if it is a small dialysis, a standard CTR is used. If it is more than 4 clock hours or moderately to severely displaced lens, different fixation devices are used. They are shown in the picture. There can be extra segment attached to the CTR. CTR ring selection is important. If the capsular rim is thinner than anticipated or is larger than the planned capsulorhexis, Sioni CTR is superior to ring segment. In long-term fixations, Sioni style CTRs, AMA than SE anchors are used. How do we go for phacoemulsification? In such cases, hydrodissection and viscodissection, they are the critical tools in managing subluxated lens. The youngest lens can be aspirated with irrigation aspiration handpieces or a cannula. Abundant use of viscoelastics have to be used. Cortical aspiration, automated coaxial device, bimanual aspiration and manual dry aspiration. It limits the stress on the remaining zonular fibers. Stripping of the capsulorhexis margin is towards the periphery, never a centripetal procedure. And the lens selection is important. It depends. If the capsular bag is intact, we have to fixate or center the circumferential CTR in place. 1 piece or 3 piece can be chosen, but avoid the accommodating IOLs because there is no zonules. There are less zonules than normal. Toric IOLs, they are avoided. Risk of decentration and there is improper alignment. So possibility of late suture breakage is there. A better alternative is limbal relaxing incisions to correct the astigmatism. Multifocal IOLs, they are most beneficial in young children with ectopia lentis because of their loss of accommodation. Increased risk of late complications is there. We have to use 8 PTFE suture, more than what is 9,0 polypropylene in cases of multifocal IOLs. So very important is to know about vitreous prolapse. If there is a subluxation, there can be vitreous prolapse. Vitreous prolapse through the cataract wound, if pulled on, it transmits the traction, we all know. What we have to do is sit back and keep calm, confirm where is the prolapse, use a solution of triamcinolone acetate 40 milligrams.
We are actually short of time. Can we just move a little fast forward?
See. So a pass plane approach is the best. Complete removal is required. This is a short video. Here capsulorhexis was done. It was about more than 4 to 6 clock hours was the subluxation. Zonules were absent. This was one of the VIP patients. Son of a VIP patient. Had a trauma with a ball while playing. CTR was implanted. Phaco was done. The cataract was soft enough, not very hard. This was the most recent patient of mine. So CTR is well placed in the bag. And with this small procedure, phaco was done, and then the capsulorhexis should be about 2 millimeters at the edges. We have to suck the lens, suck the cortical matter, not in the centripetal form. It has to be from the capsulorhexis edge towards the periphery and to be brought in the center. So there is completion of this case with intraocular lens implantation. This was a smartphone photography. It was a video taken from a phone. We are in a government setup, don't have big machines with us. Thank you so much. This is a picture taken in Australia.
Thank you very much, ma'am, for highlighting the points that you need to be careful about while handling these kinds of cataracts. Any comments, sir?
No. We are already short of time, so we conclude this session. Thanks to all the speakers.
Thank you. Copy तो नहीं हुआ हाँ, but ये चला क्यों नहीं? मैं तो नीचे करवा के आई थी.
मैडम 1 मिनट वो देखता हूँ मैं.
ऐसा कैसे?
मेरे को लगता है वही तो नहीं आपका 1 मिनट. नाम गलत डाल दिया होगा. कौन सा था वो?
3 बजे का था.
है ना?
ये तो भी होना, ये वाला भी होएगा इसके बाद. आप ही बैठे हैं अभी नेक्स्ट सेशन में.
मैडम चला तो मैं रहा हूँ.